Hey, what's up, guys? Feeling a little bit under the weather today, so just bear with me for this video case study. Thanks. So this is gonna be my video case study title number 7, an ambulance adult medical. My student ID number is 4705. Date of patient contact is 11/26/2018. The date of this case study is December 1st, 2018, and the unit number is 02 Metro 1. Shift time is 1200 hours to 2400 hours, and the disposition is Kaiser ER. My preceptor is Kanani Adams, MICT, and we get dispatched to a syncope around 2100 hours in the Waikiki area apartment complex. And when we get on scene, we find a 73-year-old male sitting. He's awake. He's kind of propped up against his bed. His back is against his bed. And he's sitting up that way. And he has a lot of blood, like all over him, and a lot of blood on the ground. We don't really know where it's coming from yet. Um, when we get closer to him, we find that he has a huge lac, like right in his forehead area. He's bleeding a lot through it. He's also got some avulsions on his right forearm. That was pretty much everything. Very like narrow apartment, very small apartment. Difficult to get the gurney in. Um, so Kanani's running the call. She's working the patient up. I'm spiking the IV bag. She's doing her assessment, and her partner Adam is looking for a vein to start an IV in. So I get the patient on the monitor and the blood pressure cuff, and he's in a sinus bradycardia rhythm going at um, about 45 beats per minute. His blood pressure sitting up is 40 over 30, I think it was. Yeah, 40 over 30. Um, so we lie him down supine with C-spine precautions, and his blood pressure comes up to around 60 systolic, and he seems pretty with it. He's alert and orientated times 3. Um, he's a really good historian. He's telling us where all his medications are, where like all pertinent information that we need for him. He knows exactly where it is. He has all his medications very um, organized, and it's stored in his medicine cabinet in his bathroom. So this guy's pretty with it, and he knows he had a syncopal episode. He called 911 himself um, after he woke up from his syncopal episode. So Adam gets the IV. We run a liter of fluid, running a liter of fluid. We're giving him a bolus right now, and yeah, his heart rate and his blood pressure were like the only alarming vitals that we found. So yeah, again, he's bradycardic at around 40 to 50 range, and he's uh, he's bradycardic, regular, weak pulse, cool pale diaphoretic skin, blood pressure 50 over 30 when we have him lying supine. As we're getting him to the rig from his apartment, he starts vomiting. We have to like make a trash bag necklace for him so that we can keep on transporting him. And so we get him into the rig. And so yeah, physical assessment. We find that his pupils pearl at 3. He just has that lac to the forehead, and the avulsion to the right forearm. No other trauma. Pelvis is stable. Chest is clear. Abdomen clear. Lower extremities clear. Um, neck and back clear. Um, no oral trauma. No blood in his ears. Yeah, so that was our pre-hospital assessment. Um, for medical history, he's on metoprolol, digoxin. Vitals were, like I said, they're staying pretty low on his blood pressure and his heart rate. Again, when we got him in the rig, we assessed his vital signs. Blood pressure was 50 over 30. Heart rate was in the 40 to 50 range, regular, weak. Temperature was good. Blood glucose level was good. Respiratory rate was good. He wasn't having any trouble breathing. Otherwise, he was a pretty stable patient, other than his blood pressure and his heart rate. Mental status was good. I did a neuro exam on him. Good. Yeah, so we were mainly really concerned about his heart rate and his blood pressure. So that's why for treatment we gave him a liter of we're infusing a liter of fluids, giving him a bolus. I think we stopped the bolus at around like 300 cc's. Oh, actually, the IV that Adam got in his left forearm, it blew when we were in the rig, so he had to get another IV in his right right foot um, right foot ankle area, because his right arm was injured from the avulsion, so we couldn't do an IV there. So we gave him 4 of Zofran, but we think that the IV was blown when we gave the Zofran, so we're not too sure if the medication actually made it to his system. He didn't really, throughout transport, he didn't have any more emesis. We did a 12 lead EKG that looked normal, didn't show any ST elevation, just showed sinus bradycardia. So Kanani was thinking at this time that the patient may have taken too much of his beta blocker medications. Wasn't really too clear on how or why the syncopal episode occurred, but we knew it was probably due to the bradycardia, low cardiac output, and the hypotension. It was round robin that day, so we got Kaiser, but our patient isn't a Kaiser patient. So, and we were in Waikiki. We didn't really want to chance it and transport him to Kaiser because of his vital signs. So, Powal 1 was actually on a call same time as us. And Kanani and Adam were trying to wait for Powal 1 to transport, so that they would transport to Kaiser, and then we would transport to maybe Queens or Straub, one of the closer in-town hospitals, or Kuakini, one of the closer in-town hospitals. So we stayed on scene for quite a bit, waiting for Powal 1 to transport. However, they didn't transport. They got a refusal from their patient, so we ended up going to Kaiser anyway. But during on scene, so because he was symptomatic bradycardia, Kanani wanted to give him some atropine, and atropine is a vagolytic drug. It's given for symptomatic bradycardia or organophosphate poisoning. We gave him 0.5 milligrams of atropine, IV push. We saw his heart rate go up a little bit to about like the higher 50, low 60 range. Then we gave the full dose of atropine, and his heart rate stayed stable at like a 63. Blood pressure started to come up. Our last blood pressure that we took after transporting him at Kaiser was 99 over 64. So that was pretty cool to see the type of medications that we carry on the ambulance, and we can use those for different circumstances and to help different types of patients. Um, Admitting physician or floor emergency room physician impression, not available. ER floor treatment not available. Follow up not available. Describing my feelings on this call. It was a pretty intense first 5 minutes of us making patient contact and looking at the patient and saying, okay, this is a sick patient. That was our general impression of that patient at that time. We saw him sitting. He was really pale. He had blood like all over the floor, all over himself. So we knew already, like, okay, this is going to be a pretty serious to critical patient. So yeah, that was pretty interesting to see, especially because our night mostly consisted of priority three and refusal calls. So this was kind of like a wake up, rude awakening for the night. And we actually got somebody who really needed emergency care immediately. So working him up right right in his apartment, I thought that was awesome. I like doing that more than bringing the patient down into the rig. I don't know, just but in the case of that patient, it was a necessity because of his his vital signs and whatnot. Um, Also, just trying to you know gauge his mental status and whatnot. I don't. I do not really condone how Adam and Kanani wanted to stay on scene and wait for Pawal one to to transport their patients so they would get Kaiser on round robin and we would get one of the closer in town hospitals. I see their point in wanting to do that because this patient first of all, he's not a Kaiser insured patient. Second of all, he is serious to the point where um, we want to transport him to the closest, most appropriate medical facility. Um, and Kaiser is pretty far off from Waikiki where we were. And so I do see where they're coming from, how they tried to beat the round robin system and whatnot. But uh, Kanani was saying that um, another option that we had was we could have called the patient a priority one and transported to Strawber, Queens. But then again, he was stable. We didn't have to really treat him very aggressively. I think lying him down um, already made a huge difference in his clinical impression, his mental status, vital signs, and whatnot. Yeah, like, is he a serious patient? Yeah. Is he serious enough to call a priority one? I don't really think so. But I see there's definitely a necessity to get him to the closest, most appropriate hospital. But staying on scene, waiting for Powal one to get a transport or refusal, or just saying okay, whatever, Metro One priority two to Kaiser, and just transporting him. Then which one would have been more beneficial to the patient? Um, Not really sure, but that's just a thought I had during the call. So the pathophys of this call. So the main pacemaker of the heart is the sinoatrial node, and that delivers a rate of about 60 to 100 beats per minute. And if that fails, the AV node will then take over, and then the Purkinje fibers. So we learned all about that, like the anatomy of the conductive system in the heart. Okay, I'm gonna quote from my reference quotation. Brady dysarrhythmias can be caused by two mechanisms: depression of sinus node activity or conduction system blocks. In both situations, subsidiary pacemakers take over and pace the heart, provided the pacemaker is above the bifurcation bifurcation of the bundle of His. The rate is generally adequate to maintain cardiac output. The need for emergent treatment of bradycardias is guided by two considerations. One, evidence of hypoperfusion, and two, the potential to degenerate into a more profound bradycardia or ventricular asystole. In general, emergent treatment is not required unless the heart rate is slower than 50 beats per minute and there is clinical evidence of hypoperfusion, or the bradycardia is due to structural disease of the infranodal conducting system that has a risk of progressing to complete AV block. Okay, so basically what that's saying there is, bradycardia dysarrhythmias can be caused by either a depression in the SA node activity or the SA node completely quits and we have another pacemaker taking over, such as the atrioventricular node or the Purkinje fibers. In our patient's case, he was sinus bradycardia on the monitor. As far as I could tell, I didn't see any AV blocks. His PR interval looked pretty good. He had a P wave for every QRS. So I didn't see any heart block that could have caused his decreased rate. So along the lines, going off of this book here, I think that it was a depression of the sinus node activity. From what I think it could have been because he may have taken too much of his medications. However, this guy was really organized, and even with a blood pressure of 50 over nada, he's AO times 3. He's telling us a very comprehensive medical history. He's telling us where everything in his house is that we need to grab. He has everything very organized, very easily accessible. So I don't think this guy would be careless enough to mistakenly take too much of his beta blocker medication. But that is a possibility. He is at an advanced age, elderly age, so anything is possible. Could have been just his SA node was too weak, just couldn't perfuse at the rate that his normal baseline rate is. So anyway, and also the need for emergent treatment for bradycardia. So the book that I have here notes that evidence of hypoperfusion is one of the findings that that you should consider if for emergent treatment, and the potential to degenerate into a more profound bradycardia or ventricular asystole. He was evidently hypoperfused. He was, cool, pale, diaphoretic on scene. There was a lot of blood loss from his laceration and avulsion, but I don't think it was enough to cause a dramatic, drop in his systolic blood pressure like how we saw on scene. Like I said, sitting up, his systolic was 40. Laying him down, systolic was 50. So he didn't lose that much blood in order for him to drop in his systolic rate like that. I think it was more due to the decreased cardiac output from his bradycardia. Um, Potential to degenerate into a more profound bradycardia or ventricular asystole. Um, this I'm not too sure about. I don't know if he had the potential to degenerate into a more profound bradycardia. Um, I guess that could be the case because his systolic blood pressure was so low that could have caused some type of myocardial injury or myocardial ischemia, maybe even infarction to the point where there could have been structural damage to his pacemakers, resulting in a AV block, um, rhythm, or ventricular asystole. So basically, like, is he gonna code? Um, from what I could see, he didn't look like he was gonna code, but his vital signs definitely indicated, ooh, like systolic pressure over 40 sitting up. If, who's to say that, if we didn't get there at the time that we got there, and he was still sitting up propped against his bed because that's how he positioned himself after his syncopal episode. You know, who's to say, like, maybe he could have coded if he was kept in that sitting position and we didn't lie him down. So yeah, I think this patient met these two considerations for emergent treatment of bradycardia. Um, so I think that was really smart of the medic to stay on scene. Get get the IV on scene, get the fluids running on scene, while we're still in his apartment, because that is one of the um, it is compromising his ABCs. It's compromising his circulatory system, so he's not perfusing very well. So some of the treatments listed in the book that I'm referencing, it does call for atropine, which we did give our patient. I will say one thing, like, his heart rate was like 45 to 50 range. We gave him the atropine, came up to 63. I was expecting a little bit of a more dramatic rise in his heart rate. I was expecting it to go to maybe like the 70 or 80s range, but it stayed pretty steady at like a 63 beats per minute on the monitor. So yeah, that's the only thing. That was my first time seeing atropine given to a patient. So just like a side note I made to myself, like, uh, the rate won't go up as many points as you think it would. Um, so that was pretty cool. The book also lists external cardiac pacing as a treatment. Because our patient was pretty stable hemodynamically after we laid him supine already. Um, I think that yeah, it wasn't necessary to pace him because he was AO times 3. Just his vitals were a little out of range. That would have been cool to see though, him getting paced. I've never seen that before. Um, but yeah, so he was pretty stable. I don't think we needed to pace him at that point. Maybe if we got on scene like maybe like 10 minutes or 20 minutes later, maybe he probably would have progressed to the point where we would have needed to pace him, maybe even code him. But no, he was pretty stable, so no need for external cardiac pacing. Okay, and that's pretty much it, guys. Thanks for listening. Hope to see you guys all soon. Oh, and this is my reference. It's Emergency Medicine, a comprehensive study guide. Um, it's written by Kellen, Actually, there's a bunch of authors, but I don't know how to pronounce their last names. Published in 2004. This is the sixth edition um, of the book, and I was reading from the cardiology section, page number 182. Um, so yeah, thanks guys. Thanks for listening. This was a really interesting case that I had while I was on clinicals. Hope you guys all had a great time on clinicals as well. I can't wait to see you guys all back in the classroom soon. Um, Good luck on the final exam, final testing. Hope you guys are studying hard. Right.